Good morning, all. Just going to wait a moment just to allow people to arrive and not miss the introductions. Okay, I think we'll make a start. Welcome. This is our pancreatic cancer webinar for primary care. I'll just introduce myself. My name's Sam Errington. I'm a programme manager at the East Midlands Cancer Alliance. One of the programmes that I'm supporting on is a new pancreatic cancer case finding pilot. We were successful to be one of 3 pilot sites in phase 1 of this endeavour. And one of the reasons we have been successful in being selected is because we committed to providing an overall training webinar for GPs and primary care colleagues to understand a little bit more about pancreatic cancer, the signs and symptoms of pancreatic cancer, tools that GPs can use to sort of consider when and how to make referrals, and also to give a general oversight a little bit more about what the pancreatic case finding pilot is about. We're joined today by colleagues from across the region, and we've got 3 speakers who are going to talk through some slides to you. We've got John Isherwood. He is a consultant how do you say this? Hepatobiliary.
Hepatobiliary.
Thank
HPB.
you.
Yeah.
Thank you so much. And a pancreatic surgeon. He's going to talk about pancreatic more generally, as sort of an expert in the field for us, and sort of give you some information about that. We're also joined by Dr. Ben Noble. He is a GP and cancer lead, and he works with us at the East Midlands Cancer Alliance as a clinical lead in primary care. His function on the webinar today is to talk about the purpose of the case finding pilot, and he'll also go through his cancer maps innovation, which can be used as a really good diagnostic tool for GPs. And we're also joined by Darren Altus. He is a CEO of the Kettering Healthcare Foundation, and he has been really pivotal in supporting us develop a protocol for our healthcare assistants to think about how they can manage patients through the case finding pathways. Thank you for joining. I'm going to hand over to John Isherwood to begin, please.
Morning, everyone. About that phone call. Try and share my screen.
Thank you.
Can you all see that? Need a yes.
Yes.
Great. So I'm John Isherwood. I'm one of the HPB surgeons in Leicester, and Sam has basically asked me to talk a bit about pancreas cancer. So we see quite a bit of pancreas cancer. Most of it is inoperable and metastatic. So it presents at an advanced state, and most patients are palliative. So basically, Sam asked me, can you see that screen? Just to make sure, because I can't see you guys.
Yes.
Asked me to talk a bit about recognition and management of pancreas cancer, some symptoms, guidelines, common presentations, weight loss, etc. So if we look at pancreas cancer, it's in the UK, it's the 5th leading cause of cancer-related deaths. US, it's 4th. 5-year survival is 8%. Okay, 8.3%. In Europe, they've increased it to over 10. In the States, it's over 10, 12%. So they're a lot better than us. 1-year survival is 27%. So, 70-80% people die in a year. Half of the people diagnosed die in 6 months. That's what I generally tell patients, and responsible for almost 10,000 deaths annually. So early detection is really critical, but there's no screening tool. Okay, so that's really why we're here. There's briefly types of pancreas cancer. The vast majority are pancreas ductal adenocarcinomas, PDACs. Okay, there's other rare ones, acinar cells, mucinous cells, but they're rare. So most of them are PDACs, and then there's this small cohorts that are exocrine tumors, the PNETs, insulinomas, grassinomas, somatostatinomas, rare, really rare, and they have better prognosis, but are really not very common at all. And then there's this cohort of precursor lesions, which are PANINs, IPMNs, so cystic lesions, and then main duct IPMNs or branch duct IPMNs. They're quite common. They rarely cause a pancreas cancer, and we're currently putting them into surveillance because we don't really know what to do with them. So patients with cystic lesion in the pancreas, the vast majority will be absolutely fine, and it's responsible for a lot of my surveillance because we really don't know what to do with them, and essentially it's an evolving field. So the symptoms of pancreas cancer are just really vague. Okay, some people present with abdominal pain or back pain. The pancreas lies pretty much right at the back of the abdomen in the retroperitoneum on your aorta and IVC. So people often get back pain. A lot of people get weight loss, and it's non-specific. Some people get jaundice if the pancreas cancer is in the head of the pancreas. And if you're lucky, it's right near your common bile duct and you present early. But we still get, nearly 40–50% of people presenting with obstructive painless jaundice. Other symptoms are vague nausea, bloating, fatigue, staturia, and then this key one, new onset diabetes. PNETs are quite vague, diarrhea, hormonal symptoms. And really the challenge is because the symptoms are vague, we can't screen for it. So the guidelines really, and I'll show you our guideline just at the end, is if you're jaundice and over 40, you trigger a 2-week weight referral, or any weight loss and abdominal pain, vomiting, nausea, change of bowel habit, new onset diabetes, over 60 will trigger a 2-week weight referral. And what we offer, so referral comes to me, and we do a CT abdomen and pelvis with a pancreas specification. If it's inconclusive, sometimes I'll do an MRI with contrast after that, or a PET scan, or rarely an EUS, but that CT goes through the MDT. All right. If somebody presents as jaundice, they have a CT, obviously, because they're obstructive jaundice, and then they have a biliary drainage, which is a ERCP or an antegrade stent. For cysts, they'll often have a CT and an MR, and if it's over a certain size or has concerning features, certain enhances, nodules over a certain size, it'll trigger a EUS. So the presentations is if you're in the head or the neck and you have painless jaundice and weight loss, you'll be referred into hospital. Body and tail, they can often grow quite big and be locally invasive or metastatic without having any symptoms. And sometimes it's just a bit of pain and weight loss. Most patients are in that 65–75 cohort. Risk factors are smoking and chronic pancreatitis and family history, but really they're non-specific symptoms and they can be misdiagnosed really easily. Advanced diseases are often metastatic, and some people even present with gastric outlet obstruction as their first sort of symptom. It shows you quite how hard it is to diagnose. So patients present late because they're non-specific: abdominal pain, weight loss, fatigue, and you can't feel the pancreas, and often they're quite hard to see. Small tumours are hard to see. You know, the CT scans will miss things less than half a centimetre, really. And often the abdomen and pelvis CT scan won't have a arterial phase protocol for the pancreas, which can miss small things. In addition, patients often delay seeking care. You know, you think, oh, I've just feeling a bit sore, and it will progress in that time. So I think Ben will discuss this further, but weight loss is a key indicator, really, and it happens months and years before, really. So malabsorption is a cause, tumor-related cachexia, and new onset diabetes. So these people are metabolic, basically, and weight loss and a rising HbA1c is strongly associated with pancreas cancer. And that's what we're going to talk about in this webinar. So I just want to show you one more thing, which is our pathway. So Giuseppe Garcia and I, sorry about that, I've drawn this up, but basically anyone who triggers these things, so aged over 60 with weight loss and any of the following: jaundice, abdominal pain, new onset diabetes, will come to a 2-week wait imaging the pathway, and they'll go to the cancer center, and then I get emailed, and I normally trigger a CT. A lot of the time people have had ultrasounds, and if there's anything concerning on that ultrasound or it shows liver lesions, I'll do a CT chest, abdomen, and pelvis. That's really up to my decision in that if I choose to do a chest or not. But then I discuss all those at PTL, and anything that shows a cancer goes to MDT. Anything that doesn't, I do a PTL letter saying you're okay. And we're pretty good at that. Our 2-week waits are about 80-90%. So it's a fairly robust, efficient pathway. I'll stop sharing if I can.
Thank you, John. That was really informative. If we can save questions till the end, that would be really helpful. Ben, over to you, please. Are you able to share your slides?
I am, yeah. Hi, everyone. So what I'm going to do now, and thanks, John, that was a really nice run through the kinds of symptoms, why it's so difficult to diagnose pancreatic cancer and the kind of symptoms we can look out for. I want to talk about, firstly, I'm just going to have a quick look at pancreatic symptoms again in the primary care setting, and how we can use the Cancer Maps, which is a cancer decision support tool, to help guide us when we're faced with difficult, vague symptoms. And then I should share my intro slide, shouldn't I? Yeah. Then I'm going to talk about the case finding pilot, why we're doing it, how it will work practically, and then I'm going to hand over to Darren, who's going to take us through in a bit more detail the steps that we're going to take as the pilot kicks off. So I'm going to kick off with a case study. So I always find case studies are best for demonstrating how difficult certain presentations can be. Now, pancreatic cancer is a little bit different because there's a requirement for an urgent suspected cancer referral of pancreatic cancer of weight loss, and once you encounter unexplained weight loss in primary care, your heckles are already up. So I think from that point of view, it's really important that as clinicians we're tuned to that. We can we always ask about it, but we always maybe check the last weight that was done if we are suspecting that there might be some kind of maybe abdominal lesion going on. So I've chosen a 64-year-old chap who's come into the surgery with a bit of weight loss, not really sure why. And on that point, I think we need to be asking around changes in diet, obviously, changes in activity, stress levels as well, because that will affect intake. And I always check. I like to demonstrate there's weight loss. So if someone's saying they've got weight loss, weigh them, because you're going to do some blood tests anyway, and you're going to bring them back, and then you can weigh them again, and just get a bit of insight. So he's got weight loss. He's got some back pain, but there's no abdominal pain. Not got any reflux. Not dyspeptic. Bowels are okay. Examine him. Can't find anything wrong. So heckles are up, as I say, because you're dealing with weight loss. You do a fit test. You do a chest X-ray as part of a screening. Blood tests, all normal. We're still facing this collection of symptoms, and this is the NG12 NICE cancer guidance for primary care, which says someone who's over 60 years old and has weight loss, and any one of those symptoms, this should be considered for further investigation for pancreatic cancer. And as John mentioned, these are often very vague symptoms. You know, abdominal pain can be abdominal discomfort. I think the key to that is progressive. So symptoms that are worsening over time, but a bit of nausea, obviously vomiting, I think is more significant. Changes in bowel habit, and then of course we come to that last bit, the new onset diabetes, which was where this pilot comes in. Just a warning, John mentioned CT scans aren't foolproof. Well, ultrasounds definitely aren't. And you've got a false negative of 30% for pancreatic cancer from an ultrasound, abdominal ultrasound. So do not be reassured by a normal ultrasound in someone who you suspect might have a pancreatic lesion or any unexplained weight loss. They need more detailed imaging. These are the cancer maps. I designed these a long while ago when the guidance came out, which was 2015, NG12, and they've come about through various evolutions and updates to the point where I think it's just a very simple tool that clinicians can use while in a consultation with their patients. I'll explain how the maps work. So you've got all of the NG12 guidelines here in 3 maps. We look at one of the maps. In the middle, you've got the organs. The second branches are the advice from NICE, whether it's a 2-week wait referral or a particular investigation. And as you come out to the periphery, you start to see the signs and symptoms that we should be looking out for when ruling out cancer in primary care. If you'll see at the top here, there's a toolbar. You can put the age and gender of your patient in. Sorry, I've just realised I've had my cursor on the wrong screen. Age and gender of your patient. And on the right here, you'll see all the signs and symptoms that occur in the NICE guidelines. So if you populate the age, gender, and start to click on your patient's symptoms while in the surgery, while they're in front of you, they will start to highlight where they occur in the guidelines. These will flash. I've taken screenshots just because it's easier than going out of PowerPoint and showing you the website and then coming back in. But these will flash. In the middle of the each map, you'll get the number of hits. And they just help to direct your attention to A, where you might be thinking about referring a patient, B, how you might want to examine them while you're taking the history, and C, the types of investigations you might want to do to rule out any of these cancers. You'll see these information icons at the end of each organ. Click on any of those. You get a whole load of extra information about that particular cancer. This is lung. Gives you some details about how common it is, the most common age diagnosis, survival figures, risk factors, and there's links to educational modules on the Gateway C cancer platform, which is a really, really excellent cancer education website, which is free to everyone in primary care. I recommend those who haven't register on that. And this is where the maps are housed. The orange exclamation marks refer to the false negatives, that slide I showed you earlier. So if you hover your cursor over any of the orange exclamation marks, you'll get a false negative, and that just helps to guide you in terms of a sense of suspicion for your patient with a normal examination. Because my sense of suspicion for a normal ultrasound and pancreatic cancer is still pretty high. And that's it. I don't want to go any further because this is about the pilot. I just wanted to let you know that this is available. It's free to use. That's the website. We'll share the slides afterwards. For those of you who aren't clinicians and are managers, I'd be grateful if you could share these with your clinicians. Some of them may well be using them already, but I think the more we know about them, the better. As I say, it's free. It's dead easy to use. I have 2 screens when I practice. I have these on one amongst other websites. You know, I'll have GP Notebook, etc. But I'll have these open, and then I'll have patient notes on the other. And as I say, if I start to get suspicious, I just bring the maps up and start to populate them. It's just so helpful, and it's not throwing pop-ups at you. It's there as a tool you can use for support if you want to, and it's not intrusive. So please use, and please contact me if you have any feedback or comments. Pancreatic cancer then. 10th most common cancer, but the 5th most common cause of cancer death in England, and John's explained why that is. As John said, I mean, my figures are slightly different, John, but 75% diagnosed late stage, 7%. I think you had 8%. You know, it depends on the bit of research you're using, I suppose. Live 5 years or more, and I would compare that with the other really important cancers in terms of mortality and incidence. So your 5-year survival for breast is 85%, prostate 89%, bowel 61%, pancreatic 7%. So you can see why we want to try and do something to improve that. I'd also point out lung, actually. Lung, I believe, you know, we know lung as the commonest cause of cancer mortality, but even that has a 16% 5-year survival. We're far ahead of pancreatic. So the idea behind case finding is that we want to try and identify symptoms that might occur before red flag symptoms. I'm not sure I necessarily agree with that, because I think the symptoms we're looking out for with this pilot are red flag symptoms, but that's the idea from the national team. We want to be diagnosing more from primary care than via emergency presentation. Emergency presentations of all cancers do particularly poorly in terms of morbidity and mortality. And we know there is a link between diabetes and pancreatic cancer. There's in 30% of patients, pancreatic cancer patients, and what we want to do with this pilot is find these patients before they start to get other symptoms. And we know that weight loss is one of those symptoms, one of those a significant number of those patients will have weight loss. And of course, what we'd expect with a type 2 diabetic is that they're gaining weight. So this is in contrast to what we would expect. It is out of the ordinary. So this is the protocol. What we're looking for is patients. This is the historic search when the pilot kicks off. We're looking for patients who have had a new onset diabetes diagnosis in the last year, over 60 years old. And of them, we want to know which ones have had a history of weight loss in the 12 months prior to that diagnosis of new onset diabetes. So we're potentially going back 2 years here. So we might have someone diagnosed with new onset diabetes kind of 12 months ago in the historic search, and then there's a history of weight loss 12 months prior to that. So we're potentially going back 2 years there, but unlikely. Having done that historic search, we're then going to go forward every 3 months and repeat that search and find those patients in the last 3 months who have been diagnosed with new onset diabetes and have possibly got weight loss. And then those patients will be invited in for screening blood tests, and those who are confirmed to have weight loss will be referred for imaging. The 2 cohorts of patients. Group 1 are over 60 with new onset diabetes in the last 12 months and documented weight loss, or importantly, a BMI of under 25 in the last 12 months. Because people with a BMI under 25 shouldn't really be being diagnosed with new onset diabetes. It's a bit weird. It's out of the ordinary. We expect diabetes, type 2 diabetes is almost end stage metabolic dysfunction. You've had to batter your system over and over and over again to get type 2 diabetes, or be very unlucky and have a really poor way of storing fat in your body such that it all tends to spill out from around your organs at an early stage. We like to, our bodies like to store fat in under our skin. Subcutaneous fat is the healthy version of fat, which we draw upon for energy. But everyone's got a different amount of fat they're able to store in their subcutaneous area, and once that's filled, it starts to spill out. And without going on too much of a tangent, because I have a bit of an interest in metabolic health. So under weight loss or BMI under 25. And then group 2 is over 6-year-old, new onset diabetes, but with no recorded weight loss in the 12 months prior to that diagnosis. We've got our 2 search groups. Search group 1, you've already established weight loss in. So you're contacting the patient to explain the pilot and invite for testing. Group 2 will be contacted, and if they give a history of weight loss prior to diagnosis or BMI under 25, they'll be invited to the practice to be weighed, and the screening blood's done if weight loss established. There are a load of exclusion criteria, which will be filtered out by the searchers. So this looks really daunting, doesn't it? If you concentrate on the grey bits, which are the primary care bits, we've got the eligible patients Where are we? Having baseline bloods. Where are we? Yeah, so they can decline the invite if they want, obviously, but those who don't will have the baseline bloods and either be deemed not suitable for CT or MRI, and that really comes back to the exclusion criteria, but may need clinician sign-off on that, or they'll be referred along a pathway particular to this pilot for further imaging. And then we come into the secondary care steps, which will be the imaging and subsequent if a lesion is found. We've looked at the numbers. They will be small, we think. These are the numbers provided by the national team. So if you consider average practice size is about 12,300, we expect there to be 3,900 of those to be over 60. We expect 30 of those to be diagnosed with diabetes per 12 months. We think 0.98 of those will have weight loss, and we think 0.3 will be diagnosed with a pancreatic cancer. That's the modelling. So if you consider a PCN, let's say with 4 average size practices doing this pilot, we'd expect 1 pancreatic cancer in that whole PCN in a year. But what we want to do is prove the concept here that this can work if we do it at a large scale. So this is the protocol boiled down. We're going to do the searches for 12 months, the historical search. So 6-year-old, new onset diabetes with either a 3% weight loss or a BMI under 25. They'll be invited in for bloods, and then they will be referred by a GP for further imaging, either directly for a scan or on the non-site specific pathway. And then we're going to continue these searches every 3 months after that. This is a bit more higher level, but I've put in some suggested timescales here. So we've done this bit. We've discussed the protocol with the stakeholder group. We've got a clinical lead for each practice and an HCA lead. The searches will be done at PCN level, and the eligible patients will be emailed to the leads for each practice. Now, we're saying the HCA lead will assess our potentially eligible patients for weight loss over the next week after receiving the email, and the baseline bloods will be done within a week following that, and then as appropriate an appointment booked with a GP for referral within the week following that. So there's a kind of a 3-week turnaround suggested. Our PCNs, we've been meeting regularly and discussing this about referral pathways. These are the preferred pathways for the PCNs. The Clifton Meadows, I think, are confirmed dropped out now, aren't they, Sam? So ignore this one. But we've got the non-site specific pathway for Sherwood and also Sleaford, and then direct access CT Abdo for Leicestershire and CT CAP for Northamptonshire. And that's about it for the protocol. I will say, and we're just discussing this before the webinar, that these are patients who have weight loss and metabolic dysfunction, which meet the NG12 criteria for further investigation for pancreatic cancer anyway. So although this is a pilot, I think there's something to be said for we probably should be considering referring these patients anyway. And even those who have pre-diabetes rather than diabetes, I think there's an argument that they should at the very least have a review with a clinician. So I just wanted to add that this is the pilot, and we are fairly clear about the rules of engagement for that pilot, but there might be more you want to do individually around that. So I'm going to hand over to Darren now, who's going to take us through things in a little bit more detail. I'll just forward on to the next slide, Darren.
Thank you, Ben. Thank you. Yeah, I just want to take us through some of those practical steps that Ben's walked through on a fairly high level, starting with the searches. So we talked about doing a historical search for the first or for the prior 12 months, which will give us some work at the start of the program, and then fall into monthly activity. When we looked at the search frequency, we made a decision to do them on a monthly basis so that we could act as quickly as possible. And if we look at the numbers that Ben talked us through for an average type practice, we're looking at a scale of probably about 2 to 3 a month that we're taking a closer look at. So what we want to do is get simple and effective processes in place so that we're working frequently but with smaller numbers on a monthly basis, so that we can act as quickly as possible. So that's our searches. They're set up on Ardens as a push button. As Ben said, we'll run them, send them through, and pick up those patients that are shown in that cohort on a new monthly basis. Next one for us, please, Ben. So we're looking at those 2 search groups. The first one is where weight loss is identified from the system reporting. The exclusion criteria, we're going to run a manual check on each of them before we book in for bloods and further investigation. The manual check is to make sure that we get it right. The HCAs can do that on the system, but we'll look at the GP to sign off on any exclusions to make sure we're getting that right. But the principle is that the vast majority of work is to rule out where there's weight loss. So those numbers where we're checking for exclusions will be quite small. The search group 2 is where we haven't got any weight loss confirmed from the system reports. We're going to check that with the individual patients and then pick up from there in baseline bloods and further investigation if that is needed. And we do that through a 1 and 2 week process, but we'll move through those as quickly as we can. But the idea is to rule out which will be the predominant action when we look at those numbers. Next one for us, please. So once we've ruled out, we expect really on that basis and the numbers that we looked at, that we'll see 1 per annum for that average GP practice size that will be it will be passed on to the GP to talk through the blood results and discuss whether there's an onward referral. We'll use the current processes, as you said, Ben, for the 2-week weight cancer pathway enacted by the GP. But what we can see is the filtering work is done by the HCA. Most are being ruled out, and then we'll refer on to the GP to pick up from that part of the pathway, and then we will refer to the existing processes we've got for those cancer referrals. So from that we refer to business as normal. So the case finding aspect is the different piece. and then we use the existing processes that we've already got as we identify them quickly and move them on for those further checks. Next one, please, Ben. So the way we're going to track activity and work through is, I think we all access and use Arden's. The pre-configured searches are already set up, so they're a push button for us. Arden templates will be used for the consultation and recording activity and outcomes. So we've got a standard template to use as we're doing the work, and then for tracking the program activity, overall program activity across the two-year program. Those who've got Arden's Manager can use that for the reporting. Otherwise, there'll be local arrangements for tracking that activity over the cohort that we're picking up from those tests and activity, which might be a spreadsheet or other computerized version of doing that. So we use Arden's Manager or local arrangements to track activity and report on a monthly basis across practices and PCNs. And we're developing a generic but relatively detailed protocol, standard operating processes that we'll share across PCN practices. Recognise that there will be some local variation on how we work, but it stands as a model for the work that we're doing. So we've looked at that in detail so that we can share the same processes across everyone that's in the program. We're just finalising that to share and feedback, so that we're working from the same book. And that's me.
Thank you to our three speakers. Really informative. I think there's some real key information there. We will follow up this webinar by sharing the slides, sharing the detailed protocol that Darren was talking about, and sharing Ben's link to the cancer maps as well for you. If you could, we will also obviously share the recording of this webinar. If you could forward on that information to your clinical colleagues and to your healthcare assistants, particularly those who are taking part in the pilot, that would be really useful. I'm just going to open the floor up to any questions. If you've got any questions for John, Ben or Darren, please go ahead. Ben.
I have a question for John. Why do the exocrine pancreatic tumours do so much worse than the endocrine ones?
They're aggressive. So they present late. They're aggressive. Chemotherapy can't really target it because of the stroma. So nothing can really penetrate that stroma. And when you take them out, they're literally behind a wall of fibrosis. So there's you know, if you look at it, there's not a good blood supply, and you know, FOLFIRINOX was what, more than 10 years ago, and before that it was just gemcitabine. So there's been no new chemotherapy agents for 50 years. All the immunotherapies, none of them have shown to work. So it's just a really difficult cancer to treat. An operation is still your standard of prolonging survival, isn't it? And you know they're going to recur. The vast majority recur in 2 years. Getting on or resection, they still recur. It's just really aggressive, and none of our chemotherapy, immunotherapy agents can target it. And there's a poor screening tool. So, holy trinity.
Yeah.
We treat it. So there's a chap. Sorry, Ben. There's a chap called David Tuverson. Do you know him? David Tuverson. He's basically a bit of a pancreas cancer rock star in the oncology world, and he works. He's worked in Cambridge, but he's gone back to the US. And he gave a good talk at one of our one of our pancreatic cancer meeting, and he described it as an oncological emergency. And I've always remembered that it is an oncological emergency. So somebody with a pancreas cancer, I see, stent, and operate within 6 weeks, basically, as soon as you can, because they spread and they don't do well. So that's how I treat them.
So the pancreas kind of hidden away there in the abdomen and not really causing symptoms. It's really well connected via blood and lymph and close to other organs.
Yes,
and therefore spreads nice and quickly.
And vessels. So
Yeah.
The pancreas, the portal veins right on it, the SMA's right on it, the hepatic arteries right on it. So you just need it to be marginally smaller to just evade those crucial structures and render it inoperable or locally invasive.
So these symptoms we're looking out for then, because I was wondering about the timescales we're using. They're long timescales, the historic search, for something which is really aggressive. What do you think about the timelines of those searches? Would you not have expected them, a pancreatic cancer, to have just shown itself by that time anyway?
I mean, I think months to years is suitable. It's not something that progresses in weeks. You know, it's not. So I think it's suitable. I think
Okay.
I wouldn't want to go further than that, but I think within 2 years is an appropriate time frame.
So we see that with lung. It will stage shift in weeks, and you know, I suppose there's a portion of lung cancers which present very vaguely. There's a portion which you know, I think most people know about cough now. So we've got a bit of an advantage with lung. It doesn't do that much better than pancreas, but I think the symptoms are better known.
The only ones, Ben, that I've seen that progress in weeks are the 30, 40-year-olds with pancreas cancer.
Right.
And their tumor biology, it's all about the tumor biology, is just aggressive. And what you basically, you got bad genes to have pancreas cancer as a 30 or 40-year-old, and it is one that will progress in weeks. Those are the ones I've seen. Anyone with a cholangio, HCC, you know, PDAC, 30, 40-year-old, they progress, but they're a small, luckily a very small amount.
And hopefully those are the ones that the Europac protocol is going to find.
Yeah. But I often see people with no family history presenting.
Right. Blimey.
But yeah.
And they're the ones that won't get found by NICE guidance, because
No,
you've got to be over 60 for that.
Yeah, they present with just you know, pain. Luckily, if your tumor is right next to your bile duct and you have an obstructive jaundice, then that's luckily. But if you have something in the body or the tail, you know, you've got to rely on that patient being really worried, or the GP being on it to go, actually something's not right here. But it's so non-specific that it's very easily missed.
Do you have a sense of what the future might be to improve diagnosis, if not this pilot?
What we need is a screening tool, basically. And there's been some really exciting work with bladder cancers and prostate cancers, I think, with certain blood tests. So if you know, if you get a blood marker, we've done a host of metabolic work, but any blood marker would be key. We still get, you know, there's a 100,000 genome project, and there's people going off for the Galleri screening tests, and I've had a few patients that have been triggered through that, and I found a HCC, found a cholangio, and they've been completely asymptomatic. So I think that sort of genomic work and sending off blood tests will be the way forward for a screening. But CTs, so the interesting thing is, if you have weight loss and you have new onset diabetes, but your CT doesn't show anything, you're reassured. But I think in the next 2-3 years, a proportion of those people will develop a cancer. And I think, I think we're falsely reassured by a CT, and a proportion of them will develop it. And I don't quite know how to answer that.
Yeah, you see some presentations, certainly I do, where I just think you didn't stand a chance. You just presented in the wrong way, and it's just really bad luck. And I should suspect most pancreatic cancer is like that.
Yeah, until our oncology catches up. And I don't know if you're aware, but so cholangiocarcinomas have really undergone a revolutionary treatment explosion, in that there is a whole host of genetic mutations, 6 new nice guidance immunotherapies for cholangiocarcinomas. So it used to be just as bad as pancreas cancer, but if you have these genetic variations and you're eligible for immunotherapy, I have seen patients who have recurrent disease, widespread recurrent disease, which has completely gone.
Really?
Pancreas cancer just isn't in that, hasn't undergone that treatment explosion. But cholangio, it's been amazing.
Oh,
yeah, interesting. During my it's the past 5-10 years, basically. It's amazing.
We need the same for pancreatic.
We do.
Thank you both. Is there any other questions from anybody, please? I'll take
All been
that.
explained so beautifully.
I think I'll take that as we're all good. Thank you. Yes. Okay. Well, we will, as I said, circulate this webinar for you to share with colleagues, with also some of the materials and resources. If you've got any questions after the event, I'll obviously you can have my email when I send the things around. So please get in touch if you've got any thoughts, or indeed any reflections about this webinar today that you want to share with us. I just want to say thank you to our speakers today. Thank you for your time and your effort, and your ongoing commitment to this cause.
Thanks for taking part.
Thank you all. Take care. Thanks for coming.
Cheers.